Great, thanks Paul. Pleasure to be here speaking to you all about this important topic. So this is probably one of my favourite graphics actually, and it illustrates my life from medical school until now. So I grew up as a single cell amoeba, trained in Cardiff. Then I became a senior reg, training here in Cardiff as a big scary dinosaur. I'm currently underneath this rock with the demands of clinical work, research, governance and everything else. And this will be me when I retire at the age of 85 as a cyborg, surviving to NHS pension. But I think it also illustrates the challenges that life has had actually since the dawn of time. Early on, dealing with oxygen was the biggest trouble. And we still see that today in paediatrics and intensive care with oxygen toxicity. Thankfully, when the atmospheric oxygen went up 4 billion years ago, we made friends with mitochondria and we can survive. Shortly after the rock, dealing with adequate nutrition was the biggest challenge we had in life. And yet, this year, more people will die of obesity than of malnutrition. In fact, the powerlifter Eddie Hall this year lifted 0.5 ton, and it was the same weight as the highest bariatric surgical patient ever known, 0.5 ton. And towards the latter end of life, where we are today, actually, the biggest challenge to you and I and everybody else is infection. Ever since the agricultural explosion in 10,000 years ago in the Fertile Crescent, living amongst people has been tricky. And that's why sepsis today is such a huge issue. Probably the biggest challenge to humanity in many ways is infection. And so I want to illustrate the research which we're involved with and will continue to do so using that paradigm of the past, the present and the future. So what about the past? What were things like yesterday? This is probably my favourite photo in life, which is a bit odd. This was a photo from 1894 in Berlin, and it was really the revolution in germ theory when Robert Koch showed this photo at a meeting, similar numbers of people as are here actually. And it was the first time we could see with our eyes microorganisms, in this case tuberculosis. It happened to be at the very same meeting another researcher called Wickerman who went on to help develop the polio vaccine, and polio being the start of intensive care as we know it, so a great meeting to be at. But the past for me, and the reason I'm standing here now, is because of this guy actually. And this is Daniel. I met Daniel when I worked in Australia. He was a young, fit, well guy, just like me. He was travelling around in a gap year, and he had a bit of a cough and a cold. But I met him when I was in the same room as his mum and dad were being told that Daniel was going to die. And for me, seeing somebody that age, fit and well, no other medical problems, that kind of changed my life as well as his actually. And I decided to take time out of clinical training to do research in infection and sepsis and commit to do intensive care as a career, and that's why I'm standing here with you guys today. And I suppose I had 3 questions after that family meeting. Why him? Why didn't the antibiotics work? And what can we do in the future to help? I can probably summarise the research evidence for sepsis up until today with 3 pictures. Number 1, antibiotics. Overall, they are great. They work most of the time. Multi-drug resistance is a bigger challenge than North Korea to our safety and security. Giving them in a timely manner, as Paul and others have outlined, is probably a good thing, although the evidence actually is not particularly strong, but absolutely they should be given. The fluid represents supportive therapies, and I think it's fair to say we still don't know actually what the best thing to do is. There's been huge trials on different fluids to give, different amounts, different times. What we know is you shouldn't give this one, which is starch. What we know is that in the longer term, after the initial stages of resuscitation, being given a lot of fluid is probably a bad thing. But that's probably all we can say. And finally, the drugs at the bottom. I won't bore you with a list of the 126 compounds which have been tried over the last 50 years to combat sepsis. The latest probably being APC, activated protein C. But it's fair to say, when treating sepsis as a syndrome and just giving these drugs blindly, none of them work. And we'll touch on why that may be in the end. So where are we today? And my apologies, this section is going to be fairly ICU-centric, intensive care-centric, in terms of the research we do, just because that's what I can speak on with more confidence. But there are huge amounts of other studies going on. There's colleagues from microbiology in the audience, pediatrics, emergency medicine, and there's a huge amount of other trials which are really important going on also. We've tried to bring together a research portfolio which attacks the various bits of this disease, both describing the problem, preventing the problem, diagnosing it, and also treating it. And so when we decide what studies to do, that's our thinking behind things. The first thing I want to tell you about is happening right now, actually. There's a group of 5 junior doctors on intensive care who've come in on their days off and are collecting point prevalence data on every patient with sepsis who gets admitted today. Similar to the study Paul mentioned, but on a much bigger scale, using very different data collection methods. In fact, there's 1,600 hospitals with 5 people coming in on their day off right now, actually contributing towards this. And so that's of huge benefit. It's called the EPIC3 project. We've just come to the conclusion of a study in intensive care where we've recruited, in 2 years, 800 patients into this. And this is using drugs, washes, antibiotics to try to prevent infection. And not only were we recruiting massive numbers of patients to this, but the way the trial was run as a cluster randomized controlled trial is fairly innovative, actually, with a no consent model to enter it as well. So we eagerly await the results of this to prevent infection in intensive care. We're also part of a multi-million European Union project, and working together with the EU and other countries in this is critical, not only essential. And this particularly looks at antibiotic resistance, which has been described as the world's biggest problem by the WHO in the last 4 years. This again is in conjunction with 800 other hospitals across the EU and working closely with the laboratories here in University Hospital Wales actually to process these samples. My research work myself looked at innovative ways to diagnose infection rather than by looking at the bugs themselves. We tried to look at the body's responses to those bugs. And this work is still ongoing. I met yesterday with a doctor from Reunion Islands, one of the French colonies, who's going to be continuing this work in our own intensive care unit. And that's also to look at the effects of immune suppression. So you're much more likely to get other infections even if you recover from initial infections. So this work is also all ongoing. In terms of treatment, we're collaborating with a number of pharmaceutical companies looking at new novel agents in sepsis. Why these will work and the other ones failed, we'll talk about towards the end. This particular one is using thrombomodulin, a coagulation factor, to reduce sepsis-induced coagulopathy. Another one will be using programmed death ligand 1 antagonism, which is normally used in cancer therapy actually, and a little praise to the fact that sepsis is a disease of the immune system predominantly, and using immune modulating drugs may be something which the future will help. Just today we've had confirmation that we'll be running a trial of using immunoglobulins, IgM, in severe community acquired pneumonia, And finally, I'm also really pleased to be collaborating with the pre-hospital services, delivering pre-hospital antibiotics, so cutting that door-to-needle time on antibiotics even further, and that's in collaboration with Chris Moore. But so what? Why are we doing all that? I've already told you 125 drugs have failed. We spend a huge amount of money, time, effort on this. Why bother at all? Why don't we just use all this money to fund sepsis boxes, quality improvement projects? Well, there's three reasons. A, research is important for the hospital and the trust. B, it's important for staff recruitment retention. But of most importance, it's important for patients. And the reason why is we know patients in clinical trials, even if they're in the control arm, die less often than those not in clinical trials. We know that units that run clinical trials have mortalities which are less than units which don't. And most importantly, this was a picture of my ward round yesterday. I was at the front. This was the advanced trainee next door holding on to the pole. There was a CT2, and just at the back you can see the foundation doctor holding the Oxford textbook of medicine. And this is called the blind leading the blind. And I'm sorry to say, even today, even in my ward round yesterday, about 8 out of 10 things that I decided to do were non-evidence based. And that's not because I am lazy or foolish. It's because that's medicine, actually. And even that 20% of things which is evidence-based, it may be wrong and may be based on poor quality evidence. If you went to medical school or nursing school or healthcare school more than 10 years ago, about 60% of things you were taught are wrong. And unless you've done something about that, or unless we find out they are wrong, the things you'll continue to do are wrong. And again, although I completely agree, quality improvement, early antibiotics, education, all those things are essential. They're also essential to go hand in hand with research. You'll remember the campaigns against meningitis, of using a glass to diagnose the rash early, get to your GP early antibiotics from the GP, carry it around with you. All of those things absolutely essential. The thing which helped meningitis C most was a vaccine, and that was from research. Again, that's why we see the dramatic reduction of about 10 years ago, 1,500 children died of this disease. In 2006, 10 children died of this disease. And that's because of hard work, research, applied money and research money. And so I'm delighted the research team are here today, actually. This is just a small selection of those who work in ICU delivering these interventions. We've recruited 1,800 patients into trials in the last 5 years, but it's hard. And it's hard for lots of reasons. The amount of money we get to do research has gone down from 11 million to £4 million in the last 4 years. It's a big unit, and we have problems with staff. And even when we have the money, getting clinical staff to work in research is a challenge, actually. And it's a challenge for us. We've got no formal university representation, even though we're probably the biggest recruited intensive care unit into trials in the UK, if not Europe. So it's a challenge, but we love a challenge, and we look forward to that challenge being met by working with others. So what's going to happen tomorrow? Well, actually, intensive care and medicine has kind of gone through 3 phases in the last decade. First of all, we wanted to make things extra good. We used to give loads of blood, loads of fluid, loads of oxygen. Don't make it normal, make it amazing. Then we realised that's not right, actually that kills you. So then we decided to be a bit more liberal, make it less, accept lower levels of blood, lower levels of oxygen. And that's probably where we are at the minute. What the future is going to be is about making it personal and not using standard guidelines for everybody, but using personal guidelines for everybody. The most common syndromes are often collections of rare diseases. Sepsis is a syndrome which consists of severe infection of your little toe, meningitis, plague, pneumonia. They're different diseases, and we have to make that personal. In terms of diagnostics, Harriet's in the audience from microbiology, and many of the techniques they use today actually are strikingly similar to this from 1894. Things have moved on a lot. We've got new techniques, we've got MALDI-TOF, we've got PCR, genetic analysis, and all those things it is hoped will revolutionise the early diagnosis of infection. This is to illustrate that we are individuals, and all these lines are people given the same substance, the substance which causes some of the reactions of sepsis, actually, LPS. These people at the bottom in red just brushed it off. They didn't even get a temperature, they didn't even really think about it. These people at the top in yellow became critically ill after having that substance. And so it's no wonder when we use 125 novel drugs against all of these people, we don't see a positive outcome. If we use them against these yellow people at the top, will there be a positive outcome? Maybe. And so I think clinical trials are moving more and more towards personalised medicine. One of the biggest papers to come out in sepsis this year was probably this paper in Chest, which used vitamin C in the treatment of sepsis. And if you read that title, it basically says we gave vitamin C to people who have sepsis, which can be an infection of your little toe or meningitis or plague, and we looked to see what happened. Okay, that's the paper, and that's probably the best paper this year in sepsis. This is from the same journal, looking at cancer, and it says, we gave people with a Cas-P7 polymorphism a specific drug designed specifically against that polymorphism for their specific kind of cancer. Okay? And that's the standard we are competing against. If I translate that into what sepsis research has looked like, it's a bit like saying we give some chemotherapy to some patients with cancer, and guess what, it didn't work. Well, of course not. You know, we need to get specific, we need to get personal. So in summary, we've learned from the past. The present has got challenges. Research is important, it's critical, it's got to go hand in hand with education, and with support from others and collaboration, we believe in the future, and we believe, and it's my hope, that I won't meet somebody like Daniel and his parents again, and instead he'll go on to live. Thank you.